Hello, a very good evening to all of you who've joined us this evening. Thank you so much for joining us on this cold November evening. I'm Rose. I'm Senior Research Engagement Manager at BHF. So a huge warm welcome to all of you to our new series of live Q&As, where you'll hear from our panel of experts and get the chance to ask them your questions. Every 3 months, we'll be bringing you a jam-packed session centered on a different heart or circulatory condition. And today we're focusing on heart failure. So heart failure is a condition where the heart cannot pump blood around your body as well as it should. In the UK, it's estimated that over 1 million people are living with heart failure, and the most common cause of this condition is a heart attack. In just a moment, we'll be hearing from Alice Timmons, who was left with lasting damage to her heart after having a heart attack back in 2020. We'll also be joined by BHF Professor of Regenerative Medicine at the University of Oxford, Paul Riley, who's going to give us a glimpse into the future of heart failure treatment. Super excited. He'll share some insights from his cutting-edge research, which aims to develop gene therapies for this condition. And we'll also be hearing from senior cardiac nurse Regina Giblin, who has 20 years of experience in supporting patients with cardiovascular disease. She'll offer practical tips, lifestyle guidance, and everyday strategies to help you live well with heart failure. But first, I'm absolutely delighted to introduce Alice, who is kindly going to share her personal story of navigating life with heart failure. So Alice is going to be interviewed by Ruth Huntman from the BHF Heart Stories team. And just a note to say that if you have any questions for our 3 speakers today, please submit them via the Q&A function. Throughout the talks, it's always open, and then at the end, we'll put all of those questions to our panel of experts. So without further ado, welcome Alice and Ruth, and over to you.
Hi, Alice. Thank you so much for taking the time to join us this evening. And can you start by just introducing yourself and telling us a little bit about yourself and your family, your life?
As Rose said, I'm Alice Timmons. I'm 71. Worked all my life, started life as a journalist, then left that, went into nursing. I've worked in social work and ended up retiring, working as a regulator, regulating care services in Scotland. I retired after having a stroke in 2010 and started my own business as a consultant to care homes for older people. Currently, I'm very happily retired completely, living in Glasgow with my daughter, my son-in-law, and my 2 grandchildren, which is the perfect setup. So I have lots of ways of keeping busy. I don't doubt we'll talk about as we go on.
We definitely will. Thanks, Alice. So your heart failure diagnosis came following a heart attack, and I know it was an absolutely huge shock for you. So can you briefly explain that journey and sort of how you found out you had heart failure?
The heart attack itself was quite unusual because I had no symptoms. I was being treated for indigestion for about a year. I had a bout of indigestion that wasn't going away the way it normally did. Spoke briefly to my grumpy GP, who had called me to check on a new drug I was taking. It was the beginning of the 2nd week of the very first lockdown, so you weren't seeing GPs or anything. After conversation, he was very dubious, but he said, just in case, we'll send you to hospital. I'm trying to keep this short. Went to hospital, my ECG was normal, my troponin levels were marginally raised, and for those that don't know, that's the marker that shows up in your blood when you have a heart attack. And the doctor I saw there also said, just in case, they would keep me overnight and give me anticoagulants. Next morning, I was seen again and was told we'll do an exercise ECG and send you home. At which point a cardiac nurse specialist came in and said, no, she said, just in case, I think we'll do an angiogram. So I was trotted off to another hospital for an angiogram, lying there desperately trying to see the screen because I'd never seen one before. And heard this sound that the sound when a mechanic's about to tell you you've got a really expensive, this indrawing breath, and it actually was the cardiologist, which is a bit worrying. Cutting a very long story short, I had a total blockage in artery on the right side of my heart, a clot in the left side, and as he was putting the stent into my heart, I fell asleep, as I thought, and woke up with a jerk. And the first thought was, I've just snored and wakened myself, and I was so embarrassed. But what had actually happened was I'd gone into ventricular fibrillation, so I had a cardiac arrest at that point. As they were shocking me and jiggling things around, the clot on the other side moved, and I had a heart attack. So cardiac arrest, heart attack, in the best possible place. With it being locked down, I was discharged within 24 hours. And there was basically no community support. I had a couple of phone calls with a cardiac nurse and a pharmacist, and that was about it. But I was actually fine. I was quite euphoric because I had survived. It was wonderful. The symptoms I'd had before that, apart from the indigestion, was that I was a bit breathless, bending down, tying my shoelaces. The stairs, I was having to use the handrail to pull myself up, and I just thought that was old age. And about 6 months after the MI, those symptoms began to come back. So I called my GP and told him that this was happening. And he said to me, you do know you have heart failure, don't you? And I said, well, no, I don't. My discharge letter said I had a bit of heart failure and they had hoped it would settle, but that was it. And I said, you definitely tell me there's a definite diagnosis? And he said, yes, you've definitely got heart failure. Now, my mother had died of heart failure a number of years before, and it was really, really traumatic. It was awful. The one thing that I've always said, this sounds odd, but give me cancer any day. The idea of heart failure just terrified me, horrified me. So he then said to me in, that nice, kind GP voice, you do know what that means, don't you? And I said, yeah, I watched my mother die of heart failure. I know what it means. For me, what it meant was I was going to die very soon and very badly. But that was the end of the conversation. Then he hung up, and that was it. I was just left there. And obviously not everybody's going to have an experience like that. But for me, it was the end of my life. I was looking at a terminal diagnosis. And I kind of just stood and stared out the window for a while, despaired. I'm the kind of person who fixes fear and anger and all the rest of it by doing something. So I went and cleared out my wardrobe so my daughter wouldn't have to do it after I died. I remember I had these red velvet shoes and giving them away and saying, that's my dancing shoes. I'm not going to be dancing again anyway. I can give them away. So it was awful. It was really very, very traumatic time. And I didn't know what to do. There was no backup. I didn't want to speak to my family and tell them and put the burden on my daughter, who's my only child. And I ended up speaking to British Heart. I was doing the stuff with British Heart Foundation on atypical symptoms, and it was their PR person who connected me with the helpline nurses. And I spoke to British Heart Foundation's helpline nurse, and she pulled me down off the ceiling. She caught me by the ankles, pulled me down and said, no, you're not going to die this week. She gave me lots of it. Even my nurse training was a long time ago, and I cared for people who had heart failure, but it was many years ago. The science has moved on incredibly, and that's one of the reasons I'm so excited to hear what Paul has to say, because things are changing so rapidly. She also encouraged me to get back in touch with my original cardiologist, who was able to put my mind at rest. I went back in, had an ultrasound, looked again, had blood tests, all the rest of it, and was able to be reassured that no, I've still got a lot of time and a lot of damage to do. But but I certainly would not want anyone to go through that level of despair again.
I mean, you've touched on it there, Alice, but you've explained beautifully before that the physical was a walk in the park after your diagnosis compared to the huge psychological impact.
Yeah.
And I think people here will be interested to hear how you came through that. If you could briefly say, how did you move forward from being in such a dark place?
I think the one thing about all of this conversation is I'm one person and everyone's different. It's going to affect people differently. People need different strategies. For me personally, it was knowledge. It was that, and I know I'm always very, very aware that I sound as though I'm putting British Heart Foundation up on a pedestal. But honestly, the information I got from publications and from people in British Heart Foundation was incredible. That encouragement and guidance on getting back in touch with the cardiologist, because I'd been discharged, and been able to get from him speaking to me like an adult, a whole group of people speaking to me like an adult and giving me information, not using euphemisms. And again, the euphoria came back. And as I say, I'm a very practical person. I've got on, if there's a problem, I'll go on and fix it. I'm probably a glass half full as well. And I always get quite emotional talking about it. But it's that thing of, I survived that. I survived the arrest. I survived the MI. I was so sure that I was going to die, and I was going to die horribly, but I survived that as well. And I think my whole attitude to life has changed. Every single morning that I'm waking up, and I know this is a terrible cliche, I think, what a gift, what a bonus. Every day is a bonus. It changed how I make decisions. I don't worry about having money put aside. Spend the money, buy the kids something, go on holiday, go for a really good lunch. I was never a great housewife anyway, but you know, I'd rather go. The thing I keep saying is my granddaughter was very small back then, and she loved hunting snails. And if you've got to choose between dusting the furniture or hunting snails with a 3-year-old, believe me, the hunting snails is better. I went on and did things that I'd only thought about before. I went to college to do a floristry course, City and Guilds floristry course, and I really enjoyed it until about halfway through, when it became really, really stressful. One of the things, again, about my personality is I'm incredibly stubborn. I would never have considered giving something like that up, but it was beginning to affect me physically. I wasn't spending time with the family, and that attitude that I'm on borrowed time and I have a bonus made me think, no, I'm not enjoying the floristry anymore. I will stop doing that. And I'm now doing a part-time class in flower arranging, which doesn't have all the financial and business side of it. I have taken up Pilates. Exercise, I keep being told exercise is important. Exercise bores the life out of me. I hate to sweat. I hate to get breathless. But things like Pilates, I go to classes and I do at home on, using YouTube videos. But I also found, again, the British Heart Foundation does a series of 10-minute living room workouts, and those are really good. I did those right at the start when I was being told, you have to take it very gently, and it was great, absolutely great. And for someone who doesn't like exercise, to actually feel good and start to enjoy doing it was quite good. So yeah, it's been quite a turnaround. I think I'm kinder to myself and to other people these days. I'm allowed to sit down and not be doing something, I don't have to achieve something every day. Reading another few chapters of my book is enough of an achievement some days. So
I could talk to you all day, but we have to wrap up and move on.
You could listen to me. No, you don't get much talking.
And I could listen to you all day, but you really are a testament to living well with heart failure. So thank you again for sharing, and hopefully we'll hear from you a little bit more later as well. Thanks, Alice.
Thanks very much, Ruth.
Thank you so much, both Alice and Ruth. Alice, thank you so much for sharing your story so openly and honestly. I think it's really important, like you said, to talk about not just the physical aspect of a condition like heart failure, but the psychological. So thank you for being so open. And I absolutely love the sentiment of, if you have a choice between dusting and hunting snails wins every day of the week. I absolutely love that. So our next speaker today is BHF-funded researcher, Professor Paul Riley. So Paul is going to share with us some of the exciting work that he and his team are doing into the future of heart failure treatment. So welcome, Paul, and over to you.
Great, excellent. All right, well, look, thanks very much, and thanks for the invitation to join this webinar this evening. And I should just say that I am BHF funded and have been since the start of my independent research career, which is now 26 years ago, and the BHF have been consistently supporting the work during that entire period. And I've been in Oxford since 2011, when I took up the Professor of Regenerative Medicine chair, which again is very heavily BHF supported. So I have a lot to thank the BHF for in continuing our work. And what I wanted to tell you about today is really, we hope that we are generating future therapies to tackle heart failure. It's early days in that regard, but this is through a very exciting initiative that started actually earlier this year, but was 2 years in the making in terms of an application process to both the Medical Research Council, UKRI, and the British Heart Foundation, who've jointly supported a centre of research excellence in advanced cardiac therapies designed to tackle both heart attacks and heart failure. And this is a collaborative project between 3 universities, King's College London, University of Oxford, and the University of Edinburgh. And that's what I'm going to talk to you about today, because we think this is a very, very exciting new development. It's a significant sum of money to support the research, a significant cohort of expert researchers from the 3 universities and beyond, including industry partners, academic partners from overseas, and with a view to building a cohort of people with expertise in certain areas of tackling this devastating condition. So we've heard a little bit about some of the numbers around heart failure and why it's such a problem. We heard about the UK numbers. Well, worldwide, 75 million people are affected. And this is 1 to 3% of the global adult population. And it is described as a worldwide pandemic in its own right. And there is a 1 in 5 lifetime risk of developing heart failure. It is the #1 cause of hospitalization, and 50% of patients are rehospitalized within 6 months of discharge. And the mortality at 5 years is still at 50%. So it's still a devastating condition with a poor prognosis. And it absorbs a huge amount of, obviously, expenditure for national health services, 2 to 3% of high income countries, and of course has a substantive burden to patients, as we've heard from Alice, the impact on her, families, care providers, and society. So it is a huge problem. And, you know, this is an article from the president of the Heart Failure Society of America. And if you look at the date in the top right-hand corner, this is 23 years ago. And I'm just going to highlight a point here that was made around this by Milton Packer. One of the most important events during the past 2 years, so this is since the turn of the 2000s, has been the repeated failure of new therapies for heart failure to fulfill their original promise to improve the management of this disease. And unfortunately, this has still been the case today. There is no curative therapy apart from heart transplantation. All of the drugs and medications that patients receive is simply to improve what heart function you remain with after the main event, the heart attack, cardiac arrest, or other disease that causes heart failure. There have been a few drugs discovered, but they were discovered back in the mid-1990s. So there's been nothing new since that period. And these are all what we call small molecules, so sort of classical drugs. Their effects are incremental. It's not transformative. It doesn't change patients' lives. They're not able to do the exercise and, have the same quality of life as a normal individual when on these medicines. And the key thing is that none of these drugs prevent the loss of heart muscle that happens during a heart failure progression, or indeed promote the regeneration of heart muscle or other tissues that are required to tackle the disease. But there are other areas of medicine that are coming online, and you'll be familiar with different types of medicines, largely through the COVID vaccine. I'm sure many people listening will have heard of the mRNA vaccine that was used to tackle the spike protein of the COVID virus. And this is an interesting development that we can piggyback on in terms of tackling heart failure. And these fall under biologics, as we call them, along with antibodies, vaccines, peptides, recombinant proteins, which are synthesized proteins, and also viral vectors for gene therapy. So this is an important part of this advanced therapy development. And these can be developed both in cells and applied to 3D tissues. Now, this is an opportunity then in terms of thinking about advanced therapies, in terms of thinking about gene therapy, so delivering genes to tackle some of the problems that are encountered by people who have a heart attack or heart failure. And we came together as 3 universities, 3 individuals shown here. Not often we're seen in lab coats now. Unfortunately, we tend to be behind the desk on our computers, but here we were doing a site visit up in Edinburgh. And on the left here is Mauro Jacka, who is head of the School of Cardiovascular and Metabolic Sciences at King's College London. I'm in the middle. And on the right is Professor Andrew Baker, who's head of the Cardiovascular Research Institute at Edinburgh, also a British Heart Foundation professor. And we established a centre, MRC BHF joint funded, in Advanced Cardiac Therapies. These were launched, if you like, and funded last year. We actually started in January of this year, and there was a big press release because this was one of the most significant investments by both the MRC and BHF in our case, but MRC through other centres of research excellence that the UKRI had made. So it's a significant 7-year plus 7-year, 14-year commitment, at which time we are tasked with actually getting a therapy at the end of that. This is not just to do lots of nice experiments and to do interesting science. We are tasked with absolutely having a medicinal product at the end of this period. And I think Mauro, who is a very good close friend of mine and is the current director of the centre, and Andy and myself will have terms of directorship over the next 7 years, summed it up very nicely in this quote, which is, as he says, this is a very exciting moment in medicine, as the time is now mature to develop a completely new category of medicines for the heart, based on RNAs and genes. This could be transformational for heart disease treatment, and we firmly believe that. So this is our vision. We want to take genes, we want to take messenger RNA or microRNAs, which inhibit genes when you add them, and put them into delivery vehicles that can get these genes into the right cell types in the heart. These will be curative. They will not just be maintaining whatever residual function the heart may have. They're easy to manufacture, store, distribute, and administer, and they need to be cost effective. We want these to be available globally and to developing countries as much as to any very high income developed countries. There are key events that happen in a heart attack and in heart failure, one of which is you lose heart muscle cells. You can lose up to 1 billion heart muscle cells, which is almost a quarter of your entire heart muscle. You lose the blood vessels with the damage that occurs downstream of a clot. And there's a big inflammatory response, which causes no end of problems if it persists in the heart. And there's also a scarring event, which is there designed as a wound healing effort, which stops the heart from rupturing, but the scar is not contractile, so it doesn't contribute to the heart function. And as a result, you end up with a non-functional area of the heart after the damage, that leads to progression towards heart failure because the heart has to compensate for that non-contracting area, and it tends to remodel. The wall gets thinner and the heart dilates. So our task is to first try some of our therapies with patients who've had a recent heart attack or myocardial infarction. That's to prevent this remodeling and this progression to heart failure. But then we would like to tackle patients with existing heart failure who have reduced heart function and fibrosis, this scarring event. So the way we're going to do this is we're going to foster what we call endogenous cardiac repair. And what we mean by that is we're going to add these key genes, these RNAs, with vector systems or delivery agents into the heart and target those cells that are already there for either heart muscle regrowth, heart muscle proliferation, expansion, or promote the blood vessels that have survived to sprout and grow more blood vessels to support that new heart muscle, and or to dampen the inflammatory response, the immune response that is causing some of the damage and persistent damage, and or to challenge and tackle the scarring that occurs and make that reversible. And we have some existing candidate RNAs and genes that we can use already that we're going to progress, but we're also taking an approach to identify more, because as you can see, there are a number of things we have to tackle in this disease through screenings. So we're going to do some high throughput drug-like screenings to identify new genes. And this just describes some of that in further detail. I don't really think I need to go into much detail here. Just to say that one of the key areas that we face, one of the big challenges, is to get these genes into the right cells in the heart so they just tackle the process we want to tackle, and that they don't go elsewhere in the body or cause some difficulty. And these will be administered. Obviously, it would be ideal if we could administer them just by an oral tablet or a drug of that type. Then they could end up in the heart through homing and proper targeting. But we can also do it by a catheter-based approach. So when a clot is removed or an artery is opened up after a heart attack, as Alice described, there's an opportunity there to actually inject with the catheter that does that role by the cardiologist to inject the therapeutic that we want to do that with. And we think we want to combine different functions. We want to make heart muscle regrow, we want to make blood vessels regrow, we want to dampen the immune system, and we want to dampen the scarring. And we have some very neat approaches to do this. We can do this in animal models, but we can also do it in human models. We can use stem cell derived heart muscle cells and blood vessel cells. We can do this in engineered heart tissue, which is human. Organoids, which are three-dimensional cultures of human cells. So we can make what we call cardioids, and we can test our gene and our delivery systems in these different model organisms that actually apply to human studies. We also have world-class imaging facilities across all three universities in which we can track in vivo, so within the animal or within human patients, what's happening with our therapies and what's happening with the effect that we're looking for. And of course, we want to take this into human patients, and we have clinical cardiologists on our team within the MRC BHF Centre who will advise on approaches of experimental medicine, so doing smaller scale studies in patients, and also things like developing new biomarkers. Alice talked about troponin T, which is a marker of the cardiac damage that you have after a heart attack that's evident in the blood. There are other biomarkers we'd like to discover that'll tell us, for example, if we're reducing fibrosis or we're changing the inflammatory response. These are the sorts of routes of delivery I mentioned. We can put, as I say, a catheter into a blood vessel in the heart at the time of when the clot's being removed, or we can use catheters to inject into hearts through remote locations, so it's not fully invasive, opening up the chest or anything major surgery. And this can be done in patients with heart failure. And so really this sort of summarizes our whole center and our ambition. It's very ambitious. Heart failure is a difficult disease to treat. And as you've seen from the history I provided, there have not been any new medicines that are curative. It's highly interdisciplinary. We need a lot of people with lots of different expertise, people who work on animal models, people who work in human systems, people who understand about gene therapy, people who understand about imaging, experimental medicine, how you stratify the right patients for treatment. It integrates a lot of components, as I've said, drug discovery, industry platforms. We need to work with industry to help us in this. And it capitalizes on established successful collaborations. So myself, Andy, and Mauro have all worked together in various different guises. So it was a natural synergy between the three of us. But also the next generation of trainees and researchers and early career researchers are all working together with this common goal. And it's very important that we have the right industry partners, as I've already mentioned, who can help us develop these technologies and also help us with product development that gets it to a point where we can take it into the clinic. And then just to close, we have an external advisory board for this centre. It consists of various individuals. There'll be some scientists, there'll be clinical expertise, there'll be industry expertise, there'll be commercialization expertise. But we also want patient representation and views from the public. So if you're interested at all in joining the board, we've got a very limited number of places, 1 or 2, but then please do scan the QR code and get in touch through that route. And Greg Palmer is our comms expert who's part of the MRC Centre, and I think he's probably listening in on this webinar. Would be delighted to hear from you, and we will be shortlisting people who might be able to join us and help us with this fantastic new initiative. And I think that's me finished.
Amazing. Thank you so much, Paul, for sharing. Super exciting work. I think even 10 years ago, when I was back in the lab myself, the thought of doing such things, gene therapies, it was on the horizon, but it didn't feel quite as palpable as it does now. So it's a really exciting time to be doing this kind of work. Not that I'm doing it, funding this kind of work. Thank you so much for sharing. Okay. So I'd like to introduce our final speaker, and that's BHF's very own senior cardiac nurse, Regina Giblin. Regina, if you'd like to join me. So Regina, I have a few questions for you about heart failure, and really pleased that you're able to join us. You have, 20 years of experience as a cardiac nurse, so you're definitely the right person to be speaking to. So the first question, I think really important, because obviously everyone on this call has some understanding, but actually the term heart failure can be quite misleading or confusing to some people. So how would you describe what heart failure is?
I just want to say, first, Rose, thank you so much, Alice, for sharing your story so openly and so honestly, and for giving us those tips about how well you live with heart failure. I liked hearing that you do flower arranging and you do Pilates, and also you do the British Heart Foundation exercises. That's really good. And also totally agree with you about what you said about information about your condition made you feel better about it. And I'm going to cover that a bit later. And thank you as well to Professor Riley sharing that exciting research into regenerative medicine, giving hope to those people who have heart failure across the UK. Nearly 1 million people across the UK have heart failure. So such an important topic to cover. So with regards to the question about what is heart failure, the first thing I would say is your heart is an organ that pumps blood all over your body. That's the main function of your heart. With heart failure, it means that the heart isn't able to pump the blood around your body as well as it should. It does not mean that your heart has stopped. It just means that the heart needs extra support to help it to function. We touched on some of the reasons why heart failure happens. The main reasons are heart attack, cardiomyopathy, which is heart muscle diseases, which can be inherited or can happen due to infection or even pregnancy. It can also happen due to having high blood pressure, hypertension over a long period of time. Other conditions that cause heart failure are arrhythmias, having anemia, having congenital heart disease. Also, cancer treatments can cause heart failure as well. So there's many reasons why people develop heart failure. And Alice mentioned this in her bit of her talk. She said, everyone's an individual, and that is completely correct. How your treatment will go, how well you feel, you know, and how the treatments affect your symptoms is all very individual, and there's no one size fits all. A good relationship with your healthcare team can really, really help. And that could be with your GP, with a heart failure nurse specialist, if you're lucky to have one, and also with the cardiologist at the beginning.
Great, thank you. So I think that leads quite nicely actually onto my next question. And Alice obviously spoke about some of her symptoms of heart failure, and as you know, you totally rightly said, it can vary from person to person. So that kind of leads me then to the question, could you tell us more about what those physical symptoms are? And also any tips in kind of how to manage those symptoms? Because I can imagine they can be quite you know, affect people in their day-to-day lives quite a lot.
So when your heart's not functioning properly, you're not getting enough blood and oxygen around your organs. So it can affect your breathing, it can affect your muscles, and this can result in different types of symptoms. The main symptoms are shortness of breath or breathlessness. Sometimes this can happen a lot at nighttime when you're trying to lie down, the breathlessness. You can feel very, very tired or fatigued or feeling weak. Another symptom is feeling faint or having lightheadedness. Some people experience palpitations. And there's another one where people get swelling in their ankles or feet and also around their abdomen. Basically, the heart is struggling to pump blood and fluid around the body. And as I mentioned, these symptoms will be treated with different medications. They can be treated with other treatments as well, such as you may need a defibrillator, implantable cardioverter defibrillator, ICD, or a pacemaker. And some people may actually need surgery, such as a heart valve disease surgery, repair, or replacement. So it really depends on why you've got the heart failure, but it also depends on the symptoms that you have. So there are, to answer the second part of the question about my tips, I've got three main ones. The third one can be probably many under one, but the first main tip I would say is to get information about your condition, find out what type of heart failure you have, find out why it happened, and then, information is key because it gives you control, it gives you empowerment to make those healthcare decisions with your team. So all heart failure patients will be started on medication because your symptoms at the beginning can be quite hard to control. So you'll start on lots of new medications, and they'll start the medications quite slowly, and they will titrate them up, meaning they'll increase the doses over a number of months or number of weeks, number of months, and they'll monitor you closely. So that means they'll check your blood pressure, check your bloods, and over time, hopefully we'll get your symptoms under control. But it's important to know that symptoms can change and the course of heart failure can change. You can go many months feeling really well, and then all of a sudden you get an infection and it might put you back, to having your symptoms back again, such as the breathlessness and the fatigue. So the medications will be changed. They could be increased or new tablets could be added. So finding out about your medications, what they are, what they're for, what the side effects are, and just trying to keep a record of all that would be quite important. The next thing I would say, the second tip, is stay active. Stay active as much as you can. Exercise is really important, as Alice was saying about the Pilates. Do exercise when you feel well. You'll have good days and bad days. Try and exercise on the good days. Think about when you have the energy. If you have the energy in the morning, then try and do some exercise in the morning and maybe rest later in the afternoon. Start off very slowly and exercise according to your own limit. Try not overexert yourself because you don't want to do a lot one day and then not have enough energy the next day. If possible, doing a cardiac rehabilitation course would be very good for you if you can, if it's in your area. On our website, there is a place you can find where your local cardiac rehabilitation class is. And I would also say that we have lots of information on our website about exercising safely. There are chair-based exercises too, but it's little and often is what you need to do. definitely staying active is really important. It improves your heart function, it improves your mood, it improves your energy. But I do know that's quite hard to do the exercise when you already feel tired, you already feel breathless, you don't know how far you can push yourself. But just take it gradually and take it slow, and you can exercise safely. And the last point I would make about helping with your symptoms would be generally to stay healthy. What I mean by that is, eating healthily is very important. Having the 5+ fruit and vegetables a day, that helps you get your vitamins and mineral into your body, and it helps protect against infections, boost your immune system. So think about all the different colors of the rainbow for your fruit and vegetables. Trying to have protein, carbohydrate, healthy fats, well-balanced meal. We do promote a Mediterranean diet through the BHF, so have a look on our website for heart-healthy recipes and about information about diet. The other things you can do to help your heart is stop smoking. If you smoke, you can ask your GP or pharmacist to help with that. And also think about your alcohol as well, because having alcohol with the heart medication, sometimes it doesn't help. And having lots of alcohol also can cause heart failure, but the alcohol itself, interacts with the medications and can cause other problems such as other cancers and things like that, and arrhythmias too. So think about the alcohol. So and the last tip, as I said, is a general tip about trying to think about the other things that you're doing in your lifestyle that can help support your heart. So eating healthy, trying to maintain your healthy weight too is another one, and to stop smoking and to reduce alcohol.
Hey, thank you, Regina. So I think what we'll do is let's bring all our speakers back to start our Q&A session. As I can't believe the time has absolutely flown. We're nearing the end of our session already. So let's bring everyone back. And hopefully when I open the Q&A, I'll see all of your questions here. So there we go. We've got everyone back. Welcome back, everyone. If you could remember to unmute yourselves now. There's a lot of questions already. So what I will do is I will start with a question for Alice. So Alice, Regina and I just spoke about the physical symptoms of heart failure, and I know that you touched on this when you were talking earlier on the kind of psychological impact. What support would you say is out there for other people who might be listening right now and thinking, I could really use some sort of, emotional support or psychological support?
That's a really difficult question for a layperson. I certainly found my support through British Heart Foundation's helpline, through the nursing staff. That's where it came from me. I think people are generally quite ignorant about what's available. I don't think I would have known about the helpline if I hadn't already been involved. And I'm trying to pull my thoughts together on this, because I know that I tend to be quite flippant about the physical side of it. Regina and I had a conversation a few weeks ago about the fact that when you have a chronic condition, you just absorb it into your lifestyle and you make changes, and you don't think about the fact that you have a disability or a chronic illness. And all the things that she was talking about, the swollen ankles, and I have blocks under the head of my bed because I cough at night when I try and sleep. But that's not the first thing in my head. The first thing in my head is fear, because I was afraid. And I'm hoping that Regina can tell us more about what support there is for those of us who have been and are still in some fear about heart failure and about its progressive nature. I think that's what worries me. It's progression and what's going to come later.
And there's a lot of questions, I think, relating to that. So Regina, is there anything you wanted to add?
Yeah, absolutely, Alice. The first thing to acknowledge is it's completely normal to feel scared when you get a diagnosis of heart failure. It's the future is quite difficult to understand, and the uncertainty of it. And I think everybody will go through a shock when they find out they have it. And, you know, they can go through like the grieving process almost. You have shock, then you got denial, then you got anger, frustration, and then maybe you finally accept it. But it doesn't just affect your life, it affects your family as well. It might be hard to tell them how afraid you are. It also might be you have to think about your future, because, you know, having heart failure can affect your job if you don't have enough energy to do the job that you're doing now, and that can in turn affect your finances. So it has many, many facets. So I think the important thing is to talk to people, talk to your healthcare team, talk to your family about your worries and your anxieties. And if you feel like you're in low mood, you know, and you're feeling very depressed, it's very important to get that professional help as well, is what I would say. And, you know, the symptoms I mentioned, the physical symptoms, but then one of the big symptoms is fatigue. And fatigue is not just physical, it's actually quite a mental thing too. And I'm not trying to belittle it to say it is, but if you feel tired and you're fatigued, it's not because you're lazy, it's because your heart's not functioning right. And it's really hard to explain to other people around you that you're so tired that you can't do something. Like fatigue is when you wake up in the morning after having a massive sleep in, and you still feel tired. It's like your batteries ran out. So when in times like that, do small things, like try and, you know, decide on what you're going to do for the day and pick one small thing and realize that you may have to, you know, plan your day according to your energy. And I would say try and focus on the positive. Alice mentioned that she's a positive person. Focus on the things you can do and not the things that you cannot. And give us a call on the helpline.
Great, thank you so much. Some research questions here. I mean, possibly a really simple one for you to answer, Paul. Do you need any trial volunteers?
It's a very good question. I mean, one of the things that we were not tasked with was setting up a clinical trial in the duration of this first 7-year period, because it was understood that that takes an enormous amount of money and time and effort, and you need to have products that you really want to be in a position to run as clinical trials ready to go. And we're at an earlier stage than that. So we absolutely would want to progress to clinical trials in the following term, but the first period, running into another 6 and a bit years now, is to develop the products and to have them ready for trials and testing. So at the moment, we wouldn't be recruiting into that. That said, our cardiology colleagues who are within the centre and in the leadership team, there is provision for them to have some small experimental medicine type experimental approaches. For example, I mentioned imaging patients and developing biomarkers and so on through that means, where we might want to reach out to patients and patient groups. But we'll make that very public, either through the website that we're developing, and we have a holding page now, which I can give you, which is www.advancedcardiactherapies.co.uk. So that will be developed in time as a full-blown web page, which will have all of the details and outreach to patients and the public and the like. So it's all to come on that front, but it's something we absolutely have to think about.
Amazing. And you've already answered another question, which was how far along the pipeline are you in developing these therapies, i.e. when do you think they may be available?
Yeah, I mean, as I say, the challenge for us is at the end of the 7-year period to have a new drug filing, so a new product. Now, that might be more than one product, or a product that targets more than one particular cellular response, as I mentioned, the sort of heart muscle restoration, blood vessel growth, and immune modulation and fibrosis. So, and that's what we need to do, and that's where we've got to push it. And as I said, we have some existing targets. We have some very good candidates that we like to get up and running very quickly, but we're also going to screen for new ones that might tackle some of the issues I've already mentioned around particular cellular responses that we want to drive.
Fantastic. Super exciting. So let's possibly head back to, I think, Alice, you may be able to speak on this, and also Regina, but someone's asked, having had a heart attack, how can you reassure adult children that you are okay and that they should not worry, you know, if you're taking steps on improving your lifestyle using medication? So that's the first half of the question. So is this something, you know, you can relate to, about telling family members how, you know, how to sort of deal with their emotions around it?
My personal experience, again, is a bit different because my only child is a paramedic.
Yeah.
So she's fairly knowledgeable and fairly she knows what's happening. I was a bit unhappy. I had asked the nurse in the ward to call my daughter to let her know about my heart attack, etc. And I said, please be truthful, be open with her. And she wasn't. She said, she phoned my daughter and said, oh, she's had a bit of a problem with her heart. And I had to explain to my daughter about the VFRS, about the MI. And as I say, fortunately, she is knowledgeable. When we talk about fear, I think the fear for our children is even worse. And I don't know, this is probably where I fall down, because I very much want to protect my child and my grandchildren. So I don't want them to know about my fears, or I find it very difficult to express and put that burden onto them. So it's maybe something that Regina has a bit more experience of, the variety of experiences, because I think mine's a bit peculiar.
So I worked in cardio rehabilitation in the NHS for about 7 years, and I met all different types of people. Some people would share with their family members what happened and how they felt, and how they do their day to day, and others wouldn't. For exactly that reason, the protection. They wanted to protect their children, and also they could be the matriarch of the family. You know, they wanted to appear strong. So the relationship with your nurses and your GP and your cardiologist to begin is very important, because there's a lot to get your head around. Not only is the physical symptoms, it's the psychological and the emotional side of things too. And it's really up to the person who's got heart failure to decide how much they want to share with their family. I know this was talk about heart attack as well. But if you're an open family, you know, talking about the risk of heart attacks is quite important to talk to the rest of the family, because you may, you know, pass down some genes, although we're learning more about the genes of heart attacks. I'm sure Paul can interject into this talk. But you know, so talking, if you can take them on your journey to look after yourself. So healthy eating, you can all, you know, make healthy food together, exercise with your children. They can encourage you, you can encourage them, you know, talk to them about their lifestyles. You know, that way you can bring them in on what's going on with you. And if they can see that you're managing after a heart attack and you're recovering well, that should give them the confidence to feel better about your situation. And obviously they're worried about you in the future. So, you know, it's things like that. So being honest about it. And, you know, we're only human at the end of the day, and we all have our own bodies and our own health, but it does affect your family. So just letting them know how you're feeling is probably, you know, the best thing you can do, instead of holding it in, because that can cause stress as well, which increases your blood pressure, your heart rate, and, you know, the vicious cycle goes on. But yeah, that's what I would say. If you can be open with your family about how you're feeling, about the fear, and also about, you know, if you need help, ask for it.
Alice, you have your hand up. Did you want to add something?
Yeah, it's just talking about the generational thing. I was the oldest of 4 children, and both my parents had major problems with cardiovascular disease. My father had his first heart attack when he was 32. It had a huge impact on me as a child, and I became a surrogate parent. And that has certainly affected how I think about how my child and my grandchildren are going to be, and how they're affected. How I was affected by that heart disease, it definitely moulded my personality. It made me what my daughter calls rabidly independent. I won't ask for help. And I try very hard, that's why I don't want to put that burden onto my family, because I had the burden from my parents. And I now kind of regret that I didn't understand. My mother had heart failure quite severely, obviously, up to the moment of her death. And I regret that I didn't understand what she was going through, that nobody had explained to me. The fatigue, absolutely, I think if I had to pick a physical symptom, the fatigue is the thing. And I wish I had known that the reason my mum spent so much time sitting down and I had to go and do things was because she physically couldn't do it. So there's a real need. That would be one of the kinds of support I think would be useful for people with heart failure. How to explain to your family what's happening and why it's happening, and that balance between telling them the truth and not placing the burden on them.
Really, really interesting discussion. And I think we've got time for one very, very quick question. And it's interesting that you touched on talking about talking to your family about, genetics and risk, Regina, because actually that was the other half of that same question. Talking to your family both about reassuring them and like you said, bringing them on your journey. But Paul, I wonder if you could sort of comment on how much do we know about the genetics of risk factors, things that you possibly can help control and things you can't?
Yeah, we know quite a lot. I mean, there's some major initiatives ongoing. For example, tackling cardiomyopathy, which, as Regina quite rightly said, can lead to heart failure. Structural heart disease, as it's called in sort of more lay language, that's being tackled at the front line really through a huge initiative that the BHF supported, the Cure Heart Big Beat Challenge. Hugh Watkins here is a very good colleague of mine, very close colleague of mine, is driving that, and all of that is genetic basis of the disease, and there's gene editing to change those defective genes that cause that disease. We also know about predisposition, in terms of high cholesterol levels and so on, and genetic, if you like, components that drive that, so that there will be people who have a genetic basis for why they have elevated cholesterol, for example. And we know about hypertension, blood pressure often runs in the family. We know there's a genetic cause as much as anything else. It's not for everyone. Of course, unhealthy living, sedentary lifestyle, exercise, as Regina says, not just for people with heart failure, but for people who are healthy. It's the, and eating healthy and being careful on alcohol consumption. All of those things are important. So there's lots of different risk factors along those lines. And of course, a revolution in terms of preventative medicine, if you like, is statins and reducing the risk of building up, coronary artery blockage and high levels, keeping the levels of cholesterol down. So we know an enormous amount about all of that, but it doesn't stop the fact that when somebody has a heart attack, and if they survive that, there is still this 30% risk, 25 to 30% risk, it still exists today, of developing heart failure, and we don't have a cure. And that's the truth. But we are working very, very hard to try and change that.
Amazing. Thank you. So I can't believe we've run out of time already. I feel like there's so many more questions, and huge apologies to anyone who didn't manage to have their question answered today. If that is the case, we do encourage you to call our heart helpline and speak directly to one of our cardiac nurses, who'll be more than happy to talk to you and help you. So you've been watching Heart Matters Live, which is a free quarterly Q&A series, a webinar, and we strive to produce the best events possible. Your feedback and comments are crucial to help plan and develop our future events. So we ask that if you could please complete the feedback survey you'll be receiving in the coming days, that would be really, really great for us. So all of our incredible research, BHF-funded research, is funded 100% by you, the public. And if you were inspired by what you heard today, then all donations to support life-saving work like Professor Riley's are very much welcomed and appreciated. So you can donate through our website or using a link in the chat box, should you wish to do so. So this edition of Heart Matters Live was recorded and will be available on our YouTube channel from next week. Our next event will take place on Monday, the 9th of February next year, and will be focused on high blood pressure and ways to lower it. And you can register now using, again, link coming in the chat box. So thanks again so much for joining us this evening, and good night.